Tekrar görüşmek güzel bir şey. Aramızda Amerika Birleşik Devletleri'nden, Cornell Üniversitesi'nden Michel Gagner bulunmakta ve bariyatrik cerrahi konusunda herkesin tanıdığı bir hocamız. Kendisi tip 2 diyabette sivil gastrektominin önemli ve bu konudaki görüşlerini bizlere sunacaklar. Kendilerine şimdiden çok teşekkür ediyoruz. Türkiye'ye ilk defa geldiği için kendisine hoş geldiniz diyoruz ve konuşmasını yapmak üzere davet ediyoruz. Biz Michel Gagner, teşekkürler.
Thank you very much for the introduction. I want to thank Dr. Arabelle for the invitation to present at this medical surgical congress. It is my first visit to Turkey. I have been many places around the world, but first time in Turkey. So thank you for the invitation. Today, and for the last few years, I've done a lot of, my main interests have been in trying to treat diabetes type 2 with surgery. And the reason is that this problem is increasing in the world. It is a chronic disease that is not only a problem in the United States, but worldwide. If we look at the statistics in 2007, obesity is 400 million and type 2 diabetes about 180. But the projection for 2015, not so far, 6 years from now, is that the type 2 diabetes will reach 320 millions and obesity or severe obesity 130 million. The cost of treating this disease in the United States for type 2 diabetes is about 132 billion and obesity a bit less. Type 2 diabetes is also the 5th largest cause of death in the United States, and there are no cures right now except for really weight loss surgery. It makes the headline every time that we have a big treatment for type 2 diabetes. This is the New York Times last year, where diabetes study favors surgery to treat obese, of course, in type 2 diabetes. 73% complete remission of diabetes. This was a randomized study looking at lab banning versus medical treatment. But if we look at surgery, even for obesity, we only treat about 1 to 1.5% of all the patients that would be candidate for surgery. And that's not even with type 2 diabetes. We don't even talk about type 2 diabetes in this overall group of patients. In the United States, when we operate for obesity, 1/3 of the patients have type 2 diabetes. So we already treat type 2 diabetes in itself with surgery. If we are operating anywhere between 250,000 of patients in the United States for obesity, about 1/3 of them are type 2 diabetes. So there's about 80,000 procedures per year that affect type 2 diabetes. And these are the different procedures. We have the bending, the gastric bypass, the duodenal switch, and the sleeve gastrectomy. In the meta-analysis of weight reduction from all the different procedures, we see that each procedure gives a different weight loss, body mass index decrease. This is the total bending, about less than 10 points of body mass index. Gastric bypass, about 16, and duodenal switch or BPD, about 18 points of body mass index. So the more the procedure is aggressive, the more weight loss it gives, and also the more resolution of type 2 diabetes we have. In gastric bending, the main resolution of diabetes is about 50%. In gastric bypass, more than 80%. And with BPD or duodenal switch, nearly 100%. So there are something about these procedures that affect the type 2 diabetes. This is another series looking at the different procedure, bending, bypass, and duodenal switch, depending on the medication after surgery, 1 year after and 2 years after. You can see that with bending, which gives a modest weight loss, a lot of patients still are on medication, as opposed to bypass or duodenal switch 2 years later. And when weight gain occurs after a successful gastric bypass, there is some recurrence of type 2 diabetes. And this is an important observation, because the hypothesis that gastric bypass gives resolution of type 2 diabetes comes from the exclusion of the duodenum. Yet, with regaining of weight, about 43% have recurrence of type 2 diabetes in spite of the duodenal exclusion. So sleeve gastrectomy is a new procedure that removes the fundus in the body of the stomach, leaving a small gastric tube with the antrum intact for gastric emptying. This procedure came from the duodenal switch, which has a combination of a sleeve gastrectomy and a very distal bypass with the ileum connected to the duodenum here. This was started by laparoscopy in 1999. We surgically mobilized all the vessels and use laparoscopy. These are energy tools to mobilize the vessels of the greater curvature. We go all the way up towards the esophagus. We take some adhesions between the pancreas and the stomach and really get the fundus removed by going up to the left crus of the diaphragm. Then about 6 centimeters from the pylorus, we put a stapler to transect and do a longitudinal gastrectomy. There's a bougie, a tube that is placed in the lesser curvature so we don't end up with a too small gastric tube. And then we continue like this to resect the stomach completely. And then this is removed by one of the trocar side. And so we end up with the fundus, the body, and a small proximal antrum being resected. We had a consensus this year in Miami, and I will share with you some of the presentations. The first is to try to understand the mechanism of the sleeve gastrectomy. If we look at gastric emptying half-time, before surgery, it takes about 96 minutes to empty the stomach completely. When we do a sleeve gastrectomy, this emptying is decreased by half, now to 48 minutes. So the stomach empties much faster. We lose 90% of the stomach, yet the stomach empties much faster. Also, what happened is there's a hormone secreted by the fundus called ghrelin, and ghrelin is an orexigenic hormone. This hormone rises when we are after prolonged fasting. The hormone rises and stimulates the appetite. But when we do a sleeve gastrectomy, these are pre-op level, and at 1 month and 6 months, the ghrelin level is reduced by 70%. So the person is not so much hungry after a sleeve gastrectomy, as opposed to bending, which does not affect the ghrelin levels. And also this is the loss of feeling of hunger, bending about 40% of this loss, and sleeve about 70%. The other interesting factor is that the transit time between the stomach and the colon is decreased by 30%. So when we do a sleeve gastrectomy, the stomach empties much faster, and also the food gets through the small bowel much faster and reaches the ileum and the colon. The transit time decreased by 30%. And what does that do to the L cells, the endocrine cells of the ileum? When the food reaches the ileum, there is stimulation of the L cells, and we have an increase in PYY336 and GLP-1. And the PYY336 has the inverse effect of ghrelin on neuropeptide Y. And when PYY336 gets elevated, we are no longer wanting to eat. So, sleeve gastrectomy is an endocrine procedure that causes decreased ghrelin and increased PYY336 and GLP-1. It's not only a restrictive procedure, it also causes these endocrine effects. Now, if we look at a large series of sleeve gastrectomy, 1,000 patients, that 78% of women with a mean age of 43 years old and a body mass index of 46. This operation is simple and takes about 78 minutes to perform with a length of stay of about 2 days. The resolution of comorbidity is quite remarkable. Sleep apnea is resolution 93%, diabetes 83% resolution, type 2 diabetes, hypertension 80%, reflux 76%, and joint pain 67%. And the weight loss over time, about 70% of excess weight loss, first and second year, and then about 60 and 50% year 3 and 4. Recently, we've collected all the series of sleeve gastrectomy, 36 studies, and we did a meta-analysis, 2,000 cases. These are all the studies included in the meta-analysis. And the origin of the study is mainly from Europe and United States, some from Asia, South America, and the Middle East. 65% of women in the 2000s cases series with the mean age of 42. That body mass index was 51 at the beginning, dropped to 37 over time. And this is a table that shows the high-risk patients with a much higher BMI. And this is the primary procedure, which is done on smaller patients. The percentage of excess weight loss is about 47% for high-risk patients and 60% for primary procedure. Complication rate is very low, and mortality is 0.17% for this procedure. It is lower than gastric bypass. In fact, it is close to gastric bending. Gastric bending has the lowest mortality, but very acceptable risk and morbidity and mortality. Remission of type 2 diabetes here in this series is quite acceptable, anywhere between 50 to 100%. Now, if we look back at the literature, we find out that 50 years ago, there was an observation that when we did subtotal gastrectomy, type 2 diabetes was ameliorated. And this came from operations done in Brooklyn for ulcers or other reasons. And it was forgotten. Recently, we looked at a small cohort of patients with sleeve and type 2 diabetes with a very high BMI of 58. And we saw that even in this big group of patients, we had 2/3 complete resolution of type 2 diabetes. And 1/4 was improved. So the total was 91% of the patients were affected by the sleeve. These are the drop of hemoglobin A1C in the patients who had cure from 6.6 to 5.7 and from improvement from 7.2. 9 to 7.4. The University of Barcelona looked at this also. This is at 4 months, comparison between gastric bypass and sleeve. The percentage of excess weight loss is the same, and the resolution of type 2 diabetes appears to be the same, no significant difference. And at 1 year, the same data published last year shows that gastric bypass or sleeve gastrectomy have similar resolution of type 2 diabetes, about 85%. There's also a randomized study comparing gastric bypass and sleeve, and they looked at the hormones, and they had similar weight loss between the two procedures. There was an increased postprandial plasma insulin and GLP-1 in both of the surgical procedures. There was an earlier augmented insulin response from bypass, but at 3 months, that insulin and GLP-1 secretion was the same in the two procedures. So now I'm going to shift to even more new procedures, and that is the endoluminal-duodenal tube. And this is a cheap plastic tube of 10 cents. And one who has worked with Dr. Milone remembers the study we have done at Cornell, which is implantation of this tube after the pylorus, so that the tube inserts in the proximal small bowel. The food goes inside the tube and doesn't touch or get absorbed by the duodenum, the proximal intestine. But the bile and pancreatic juices flows between the wall of the tube and the intestine, so that the two mix together here for absorption of fat and other proteins. The animals that don't get the tube, they grow normally. When you put a 6-feet tube, there is a modest growth, and a 12-feet tube, there is a regression of weight. So this is very interesting in that you can modulate the response by the length of the tube. But we have some problems in anchoring. The tube does not stay there permanently, and can pass, and material can crack, and so there are some problems with the method, and also the tube can twist and cause gastric obstruction. A company called GI Dynamics has used the concept with a nitinol stent and a small polymer called fluoropolymer, much thinner, is introduced by endoscopy. The stent is placed right after the pylorus. The tube is shorter, about 2 feet, which is about 60 centimeters. This is the first result of the human trial. And when the weight loss at 24 weeks, 30% excess weight loss. So very good weight loss with the tube in place. Compared to the control. These are two trials, you can see the difference. Now, in type 2 diabetics, when you place this, over time, the glucose tolerance curve at the beginning starts to go down with time, so that it reaches a normalized curve by 24 weeks. So, is it a weight effect, or is it a decreased stimulation of the duodenum and proximal GI tract? Nobody knows. There is now a new trial with a more aggressive tube. This tube is placed in the distal esophagus and causes the sleeve gastrectomy effect combined with the duodenal tube. Now this tube gives a weight loss that is twice as much as what we see with the duodenal tube. We reach 30% excess weight loss at 12 weeks, not at 24 weeks. And so this will also, although only 8 patients have been entered in the trial in Mexico, it is likely that the resolution of type 2 diabetes will be even more rapid than with the duodenal tube. So now I get to another new procedure called SGIT. The SGIT is the combination of sleeve gastrectomy and an ileal transposition. What is the hypothesis of this? If we take a segment of ileum and we placed it in the proximal GI tract, we cause an early stimulation of PYY336 and GLP-1. If we do a sleeve gastrectomy, we have a decreased ghrelin levels. So if we combine the two together, we really have an additional effect of what we want to see in these types of surgery. If we take a segment of ileum of 10 centimeters in the rack and we put it here, the absorption appears to be the same because we don't remove any intestine. The body weight after 45 days in the rats are less with ileal transposition than with the sham, in spite of normal absorption. What we see is a rise in GLP-1 in ileal transposition compared to sham, and a rise of PYY336 compared to sham. And so this procedure should give the best of both worlds, because by leaving the intestine intact, we should not see micronutrient deficiencies that we see with gastric bypass and other bypass procedures. The rise in PYY336 and GLP-1 and the decrease in ghrelin will have a double effect on neuropeptide Y in the hypothalamus. This is the experiment we did in the pig with sleeve gastrectomy and ileal transposition. We have 4 groups. This is the sham with the weight over time. This is the ileal transposition, and in the pigs have less weight with simple ileal transposition. This is the gastric bypass and SGIT, sleeve gastrectomy with ileal transposition, and they have much decreased weight at 15 weeks. But these pigs were not morbidly obese. So then we went and did a rat experiment with morbid obese rats and did the same series of experiments with rats with sham, and here we have gastric bypass, and here sleeve gastrectomy with ileal transposition. The fasting glucose in these animals in the sham groups was elevated, gastric bypass about 30% less, and ileal transposition and sleeve gastrectomy with ileal transposition had the lowest glucose. And when we did glucose tolerance tests in these animals, sleeve gastrectomy with ileal transposition had the lowest curve. Insulin tolerance test, again, sleeve gastrectomy with ileal transposition had the lowest glucose level. Ghrelin was also very low in sleeve gastrectomy ileal transposition, as well as with Roux-en-Y gastric bypass compared with sham. And PYY336 elevated. So with these rat and porcine experiments, we decided to go in humans. And in 2005, wrote a paper in French, which was the ileal transposition with or without sleeve gastrectomy in humans. And we proposed this operation. The problem is we did not know how long of a segment of ileum we needed to transpose and where to put it. Because the ileum can be put between the esophagus and the stomach, between mid-portion of the stomach, or between the duodenum, or between the jejunum. So there are 4 positions for the ileum to be transposed. Right now, intraduodenal and interjejunal have been tried. In 2006, a report from Aureo de Paula from Brazil on a pilot study of 18 patients with sleeve gastrectomy and ileal interposition. Here's the sleeve gastrectomy, and 100 centimeter of ileum is taken to be put here 50 centimeter distal to the ligaments of Treitz. So they are 1, 2, and 3 anastomosis. The first series of 19 patients of BMI of 40 showed a 38% body weight loss and reversal of all the type 2 diabetics, only 5 patients. So then he went on to do smaller patients, only diabetics, 60 patients with type 2 diabetes with a preoperative BMI of 30. So now they are overweight, slightly obese, with a mean duration of diabetes of 10 years. This is again the sleeve gastrectomy with ileal interposition, and there's also another series of patients he did with the sleeve gastrectomy with the ileal interposition interposed with an extrusion of the duodenum in a wide fashion. So a more complicated SGIT procedure. Now, from BMI of 30, it went down to 24, so there is a modest weight loss, and 87% had adequate glycemic control. Now remember, these patients have been diabetic for 10 years, so this is very interesting. And the comparison between the diverted and the non-diverted, which I've shown you, showed a better decrease in hemoglobin A1C with the diverted one, down to 5 versus 5.65. So we get with SGIT hemoglobin A1C down to 5 with this kind of procedure. But I have to tell you that the diverted sleeve gastrectomy looks very much to the duodenal switch, which has been done since '88. And in the meta-analysis I showed to you at the beginning, this procedure had nearly 100% resolution of type 2 diabetes. So there are elements of the switch and to the diverted sleeve gastrectomy that causes the resolution of type 2 diabetes completely. Another procedure that has been seen recently is called the duodenojejunal bypass. And what is it? The stomach is intact and the duodenum is cut off and the proximal jejunum is brought here. So the food goes in the stomach through the pylorus into the jejunum. And the duodenum here is closed, but brings the bile and pancreatic juice on the side here. That's called the duodenojejunal bypass. This procedure was known as the switch procedure for bile reflux by Dr. Demister. It was also known in the 20s as the Mann-Williamson operation, which was a model for ulcer, to study how ulcers were happening. So the problem with this procedure is that it's an ulcerogenic operation. But Dr. Rubino, which was a fellow in my lab for 2 years, did Gotokeki's Zaki rats, which are spontaneous type 2 diabetes, and did duodenojejunal bypass versus sham, and had plasma glucose going from 159 to 96, and proposed that the exclusion of duodenum is really the mechanism. The food intake with duodenojejunal bypass is decreased compared to bypass or to sham animals. Weight gain is less with duodenojejunal bypass. Ghrelin is slightly decreased. Insulin is up. And glycemia is under control. But the problem with this experiment is that it has not been repeated by other teams. Larger mammals have not been tested, and it is known as an ulcerogenic operation. Nevertheless, in Brazil, Dr. Cohen started to do this operation and started to do 2 patients, which he published in 2007. And more recently, a series of 35 patients was done with this procedure. And the mean operative time is 46 minutes. They had 1 mortality, some complication of obstruction or prolonged nausea. The hemoglobin A1C with duodenojejunal bypass went from about 9 to close to 6 at 6 months. Plasma glucose dropped, and also a modest weight loss. But on the 6 insulin users out of the 35, 5 remain on oral hypoglycemic drug, and 1 on insulin at 6 months. So not so sure that insulin-dependent type 2 diabetes will be treated with duodenal bypass. Another group from Sao Paulo, Dr. Ramos, had a body mass index drop from 27 to 24, and the hemoglobin A1C over time went from 8.8 to 6.8 at 6 months with duodenal bypass. And to counteract that, Dr. Fursley, who's done also 7 subjects with duodenal bypass, had not seen a dramatic drop of hemoglobin A1C at 1 year with this procedure. And if you look at the patients who were on medication, 4 were on insulin and 3 on oral hypoglycemia, 12 months later, 3 remain on insulin, 3 remain on medication, and 1 had complete resolution. So I think that duodenal bypass in itself is not an operation that will continue to be there for resolution of type 2 diabetes. One of our fellows from Italy who was in the lab at Mount Sinai at the time did a study on laparoscopic sleeve gastrectomy combined with duodenal bypass. And we looked at this more than 8 years ago for weight loss, and it was a good procedure for weight loss compared to sham animals. And interestingly, Dr. Kasama from Japan in Tokyo has just published a series of patients which has sleeve gastrectomy with duodenal bypass on 21 patients. And the weight loss was 37 kilo, or nearly 96% excess weight loss. They had 1 leak, and resolution of diabetes was 96%. Some other studies that have compared ileotransposition and duodenal bypass in the animals, in the rats, have shown significant reduction of blood glucose, no difference between the 2 operations, and etc. So I'm going to conclude here that there's a lot of excitement in gastrointestinal surgery for the treatment of type 2 diabetes. And sleeve gastrectomy appears to be the simplest procedure, because if we have 320 million people with type 2 diabetes on the planet to treat by surgery, potentially, the sleeve gastrectomy may be the procedure of choice because it has the lowest morbidity and mortality, and has about 85% resolution of diabetes with this procedure. The sleeve gastrectomy with an ileotransposition is a very complex procedure. I think it should be considered still experimental when you think that you have 3 small bowel anastomosis on top of a gastrectomy. It has likely a much higher rate of mortality and morbidity, and potential risk of leakage and also of internal hernia and small bowel obstruction is much higher. So I would not do this as an initial operation for type 2 diabetes. Duodenal bypass you've seen. We think that, again, this has 2 small bowel anastomosis, and if it's not combined with a sleeve gastrectomy, it's likely to give ulcers in the jejunum portion, and this will be an increasing morbidity in the patients over time. The anti-diabetic effect is not as good as sleeve gastrectomy, but when the 2 are combined, this may have great potential, nearly 96% of resolution of type 2 diabetes. But what I would say is that it's perhaps better to do a sleeve gastrectomy and get resolution of diabetes in 70 to 85% of patients, and if they fail, we can add a duodenal bypass after. This would be rather an algorithm that would work rather than do everybody with a sleeve gastrectomy and a duodenal bypass. What about the tube? Well, the tube is promising, but the problem is that after 6 months, we have to remove the tube. The anchoring of the nitinol stents creates some potential migration of the stent into the wall of the duodenum, could impinge on the gastroduodenal artery and cause major hemorrhage, or fistula or infections, migrations and twisting of the tube could be a problem long term. So I think that this is a temporary measure, but it's unlikely to be a permanent solution. So I think that these trials are very interesting. It's important that the surgical community, the endocrine surgeon, and the endocrinologist are aware that these procedures are emerging and could be a great potential for the treatment of their patients. We are facing a huge epidemic, and let's face it, giving medication and insulin is not treating the disease. You are controlling the disease and potentially the diseases that follows diabetes. But if we have a surgical procedure that could create complete resolution of type 2 diabetes, I think that this would be preferable for the patients, especially if this procedure has very low morbidity and mortality. Thank you very much.